First of all, I would like to thank the organizers for giving me the opportunity to share with you some of the results of the Alienor study. It's really an honor for me to be here among so prestigious speakers. So I am going to talk about the clinical determinants of the macular pigments in the Alienor study. Here is my financial disclosure, and I would like to mention that the study received financial support from Laboratoire TEA. Let's begin by the beginning, and I would like to tell you how was born the Alienor study. Actually, the Alienor study is an ancillary study of the 3CT study, and the 3CT study is an ongoing population-based study on the vascular risk factors for dementia. And this study is taking place in 3 French cities, Bordeaux, Dijon, and Montpellier. The 3CT study included 9,294 subjects. All the subjects were aged 65 years or older. They all were volunteers, and they were drawn by lottery from the electoral lists of these 3 cities. In Bordeaux, 2,104 persons were recruited, and the study started between 1999 and 2001, with a follow-up every 2 years since. At the third follow-up, I mean between 2006 and 2008, an eye examination was proposed to all participants of the 3CT cohort in Bordeaux. And at this time, among the 1,450 subjects re-examined, 963 accepted the offer and so participated in the Alienor study's baseline eye examination. So the aim of the Alienor study was to assess the association of age-related age disease with nutritional factors. So how it is the way the Alienor study was born. On this graph, you can see the Alienor study design. So there is here the start of the 3CT cohort and the follow-up every 2 years. And at the third follow-up, the beginning of the Alienor study with the ophthalmological eye examination. At baseline, blood samples were taken for genetic factors, but also for plasma lipids and carotenoids measurement. And there also was an evaluation of the vascular risk factors and an evaluation of the cognition status of the cohort. And this evaluation was performed at each follow-up. So at baseline in the Alienor study, subjects were at least 74 years old. And among the 963 participants, 879 were gradable for AMD. And we found late AMD in 49 subjects, which represents 6%. And we found an early AMD in 23% of men and 31% of women. You can see that these results are consistent with those already published in cohorts composed with old subjects. So today, the purpose of my talk is to determine whether individuals' clinical parameters are associated with a difference in macular pigment optical density, which has been measured with the 2-wavelength autofluorescence method in the Alienor study. Actually, 18 months after the baseline examination, a complementary eye examination was proposed to subjects in whom an early AMD was diagnosed, and to an equal number of normal subjects. And in addition to the eye examination, we measured the macular pigment optical density. So on the same graph I I showed you earlier, you can see here the macular pigment measurement between baseline and the first follow-up of the Alienor study. The eye examination represented a best corrected visual acuity measurement. We also evaluated the lens stature of the population. Indeed, people had whether an intraocular lens because of cataract surgery or a natural lens. And in this latter case, we graded the lens according to the LOX2 classification. So we had 4 groups, a group with a clear natural lens, which was possible even if people were at least 74 years old, a group with nuclear cataract, and in this group we graded people in nuclear cataract when the opacities were over 3. And a group with cortical cataract if the opacities of the lens were over 0.5, and a subcapsular cataract if the opacities were over 0.3. Concerning AMD, we performed 45-degree photographs with a non-mydriatic retinograph, and we graded the photos according to the international classification. So I remind you that in the international classification, we had late AMD when there are atrophic or exudative lesions on the photos. Early AMD if there are soft drusen, reticular drusen, or pigmentary abnormalities, and normal if there is no AMD lesions on the photos. We measured macular thickness with a spectral lithosity, and the measurement was performed at 1,000 and 3,000 micrometers of diameter, centered by the fovea. We performed some autofluorescence imaging with a spectral lithosity, and finally, we measured the macular pigment optical density with the 2 wavelengths autofluorescence technique using the modified H-array. I just want to precise some aspects of the autofluorescence methods. As you know, in this technique, macular pigment optical density measurement is based on the macular pigment's attenuation of the fluorescence of the lipofuscin in the retinal pigment epithelium. Lipofuscin is excited at 2 laser wavelengths, 488 nanometers for blue light and 514 nanometers for green light. As you know, and you can see on this graph, that the blue light is very well absorbed by macular pigment, while green light is much less absorbed. But these 2 wavelengths are able to excite the lipofuscin, and the fluorescence emitted by the lipofuscin is about 620, 630. And so in order to avoid the lens autofluorescence, but also to restrict the lipofuscin detection, a barrier filter at 530 nanometer is added in the device. So macular pigment is calculated according to this simplified equation, in which there is a subtraction of 2 ratios. And here the ratio represented the fluorescence with the blue light over green light in the periphery, and here autofluorescence with blue light over green light in the fovea. This is an example of what we can obtain with this method. There is here an image with a blue light, and you can see very well macular pigment. The same fundus taken with green light. And the software is able to make a subtraction between the 2 images, and we obtain here a macular pigment map in which macular pigment appears bright and white, and then the software transformed this gray scale into a curve with figures, and so we can obtain the optical density of macular pigment at any eccentricity. Here, the red circle is at 0.5 degrees of eccentricity, and the green circle is at 6 degrees of eccentricity, but we can choose any eccentricity we want. Concerning clinical data, we recorded body mass index. We asked people about their smoking status, and the plasma fatty acids and macular carotenoids were measured from fasting blood samples collected in 1999 and 2001, so at the 3 CT cohort baseline. Among the 395 included subjects, some of them were excluded. 66 because of late AMD, 94 because of other macular diseases like macular hole or macular edema, and 30 participants because of a supplementation with lutein and zeaxanthin. So among the remaining 206 subjects, 181, which represents 321 eyes, had complete data. Concerning statistical analysis, the association of MPOD with the clinical parameters were estimated using multivariate mixed linear regression models, taking into account data from both eyes and their intra-individuals correlations. Here are the results. The results were obtained after adjustment for age and gender. And we found that MPOD within 0.5 degree increased with increasing plasma lutein and zeaxanthin. And this result is highly significant. We also found that MPOD decreased with increasing body mass index, and it is also statistically significant. But on the other hand, we didn't find any association between MPOD and plasma omega-3 fatty acids or smoking status. Concerning the variation of macular pigment optical density according to lens status, there is here a table of the results, and the results are for MPOD within 0.5 degree. And you can see that people with cataract extraction, I mean within intraocular lens, people have a higher macular pigment optical density than reference, and this is significant. And people with nuclear cataract have lower macular pigment optical density, and this is significant. We didn't find any correlation with the two other kinds of cataract. And if we look at the results concerning MPOD within 1 degree, the results are quite similar, as we found higher MPOD in eyes with cataract extraction and a lower MPOD in eyes with nuclear cataract. Concerning correlation with retinal parameters, the MPOD within 0.5 degree tended to be lower in early AMD, but this association did not reach statistical significance. And we didn't find any significant association of macular pigment optical density with abnormalities of autofluorescence, whether they are hypo or hyperautofluorescence or reticular drusen. And finally, no association of macular pigment optical density with retinal thickness was found at any eccentricity. So we have here an analysis of the association between MPOD and clinical parameters in the elderly. And as you saw, some results are similar to previous studies. Indeed, we found an increased MPOD with increased plasma lutein and zeaxanthin, and we found a negative correlation between MPOD and body mass index. These results are well known. They have been already demonstrated in numerous studies, and yesterday in the Carets, we saw that the results were similar. But at the opposite, we didn't find any correlation between MPOD and omega-3 and plasma omega-3 fatty acids. Yesterday, also in the Carets, positive correlation was shown. But to our knowledge, there is no so many studies focused on this correlation between MPOD and plasma omega-3. Apart, the studies related to omega-3 supplementation. So there is CARET, we saw yesterday, and also the Pimavosa study conducted by Delifer and al. And in this latter study, the authors found also a positive correlation between MPOD and plasma omega-3 fatty acids. But anyway, here we didn't find any correlation. So our hypothesis is maybe it's because the omega-3 fatty acids were measured from blood samples taken 10 years before. So people might have changed their diet in the intervening years, and that could be the reason why we didn't find any correlation. Concerning MPOD with smoking status, we think that the results is not very interesting in this case because we have in the cohort we have very few active smokers, and so that weakens the results. And concerning past smokers, actually they had all stopped to smoke more than 20 years ago. So we think that after 20 years, the macular pigment should be similar to a normal people, a non-smoker at least. Concerning correlation between MPOD and retinal parameters, we didn't find a correlation between MPOD and early AMD. As you know, there are many studies related concerning this association, and actually there are many controversial results. Indeed, the first studies demonstrated, as we expected, demonstrated a negative correlation between MPOD and early AMD. But now the recent ones demonstrated either no correlation or sometimes a positive correlation between MPOD and early AMD. And these later results is really surprising. And we found that, for example, in the Mars study, or in a subcohort of the AREDS-2 conducted by Dr. Bernstein. And in the latter case, the hypothesis is that people aware of having an early AMD are prone to take on their own a supplementation with lutein and zeaxanthin. So maybe that could explain the positive correlation between early AMD and macular pigment optical density. But anyway, in the Alienor study, we didn't find any correlation. We didn't find also no correlation with optofluorescence abnormalities, but we think that it is because of the method we chose for measuring the optical density. It's autofluorescence, so it's hard to demonstrate any correlation with autofluorescence abnormalities. And concerning macular thickness, to our knowledge, there is only one paper showing a correlation between the macular thickness and MPOD. Here we didn't find any, but maybe it's because the way we measured the macular thickness is not enough accurate. But we found a significant association between MPOD and lens status. Indeed, we found that eyes with intraocular lens have higher MPOD when eyes with nuclear cataract have lower MPOD. So we think that these results are related to the autofluorescence method. Indeed, as you know, blue light is partly absorbed by nuclear cataract because nuclear cataract is yellow and yellow absorbs blue light. So our hypothesis is that if we change one part of the ratio in the equation. So if we change this part, of course, we will change the results at all. That could be an explanation, the absorption by the lens. And that could be the same explanation for the higher MPOD in IOL, because you know that IOL absorbed or absorb there is no absorption or minimal absorption by IOL for blue light. Concerning the two other kinds of cataracts, one hypothesis is that there is an inhomogeneous blue light absorption by these types of cataracts, but more likely it is because with this kind of cataract induce a very bad quality of images. So probably most of the people having this cataract have been excluded because of bad quality and in the autofluorescence imaging. So that's probably the explanation. So in conclusion, I would like to outline that the two-wavelength autofluorescence method is influenced by cataract. To our knowledge, there is only one paper which has demonstrated the same results. It's Sasamoto. In this paper, he measured macular pigment optical density just before and just after cataract surgery, and he demonstrated that people with nuclear cataract have an increase of the macular pigment optical density just after the cataract, the cataract surgery. And his hypothesis in this case is just because as the emission and excitation light is scattered by the cataract, in order to obtain a better quality for the image, for the autofluorescence, we increase the sensitivity of the detector, so we increase the noise of the image, and so we increase the reflectivity of the image, and so that changed the results in the fovea without any change in the periphery. So that's the hypothesis of Sasamoto. But so I would like to conclude telling that care should be taken when using this method of autofluorescence in cohort of old patients. And before leaving, I would like to thank my co-authors, my co-workers, and especially Cécile Delcourt, who is the true leader of the Alienor Study. Thank you for your attention.
Thank you very much, and we're open for questions now.
I live in France for about 8 months of the year. It's a wonderful country. I'm surprised that there is so much AMD in France, and I do meet it where I live. Older people seem to have a very high instance of it. What I wondered is whether you have actually measured what we call the number of people with atypical macular pigment, which is called a central dip. Somebody yesterday called it a ring structure. What it means is that the macular pigment is higher at 0.5 than it is at 0.25. Now, in Ireland, using the densitometer method, they find that 14% of people have this abnormality, if you can call it that, or condition, where in London, using the spectralis, which I think gives a higher instance of this particular, what you might call condition, about 20%, say, in London. Have you examined how many people in your group had this condition? Because what we believe is that it's due to the absence of zeaxanthin and mesoxanthin in the central portion. And it may be that these people have a defect in the conversion of lutein to mesoxanthin. And of course, that's highly speculative, but it's something which we could consider. So I wondered whether you have done what I asked you, whether you have measured this atypical distribution.
No, that's a good point. Actually, we didn't look at the macular pigment distribution, is what you ask. Actually, we didn't. We just measured the macular pigments at different eccentricities. So I show you 0.5, 1 degree, and also 2 degrees. But actually, we didn't try to make any correlation between early AMD and the macular distribution. But that could be a good idea. But we didn't look at.
Yeah, I definitely recommend that. There's so much more data that you have there that you can kind of, looking at the total amount under the curve and the distributions that you,
Okay.
It would be very useful to continue to use
Probably,
that data.
yeah.
Just, and don't just concentrate on the 0.5. There's much more there.
Okay.
Okay, other questions? Yes.
Yeah, along the same lines, I wonder, Marie-Bénédicte, if you exclude people who have conditions for which diet change or supplement use is recommended in recent years. So people that have just started using supplements or eating more vegetables might have had a recent increase in macular pigment, which may not represent a causal association. And so we found in CARIDS, when we looked separately at people who had these conditions that diet change is recommended for or had recently begun using supplements, that we did find the direct association between macular pigment and early AMD, but then when we excluded those people, we found an inverse or negative association, protective association. So we think that our original results might have been confounded by recent changes.
You're right, that's a possibility, because we think that in the 10 years, in the 10 intervening years, of course, people could have changed, not only because they decided to take some supplementation, but because they are older. And when you get older, you don't eat the same diet than when you are younger, just because of I don't know, of teeth, it's going to the market could be difficult, so you can't buy the same. I don't know. There are many reasons, and that's probably a good explanation of that, because we think that there must be a positive correlation between omega-3 and macular pigment optical density, of course. But we found a positive correlation with plasma lutein and zeaxanthin, but not with omega-3.
Yeah, and I was thinking about the relationship between macular pigment optical density and early AMD.
Ah, okay, and early AMD, okay, I understand. Yes, yeah. So we have a tendency of a negative correlation, but only a tendency. So, or maybe we didn't have enough people for showing a positive result. That's another explanation, because we don't have so many people with an AMD, actually, with an early AMD. That's another explanation.
Okay. Next question. We have two here. There's also one here.
Hello. Please, did you look at the effects of different IOLs on macular pigment?
Actually, in France and especially in Bordeaux, most people have a yellow IOL with a blue stop for. So that is your question? Between white or yellow
yeah,
intraocular
and
lens?
also sometimes maybe anterior chamber or posterior chamber IOLs.
All people had posterior lens, all of them. For that, yes, I'm sure of that. There is no people with anterior segment, anterior intraocular lens. Okay. But between white and yellow intraocular lens, actually, we performed, before this study, we performed a short study between white and yellow lens, and we didn't find any difference between macular pigment optical density. So we didn't look at that for this study.
Question here.
Since two-wavelength autofluorescence is affected by nuclear cataract, would it be possible to grade people based on the amount of nuclear cataract to create a nomogram so that after they've had cataract surgery and you can get an exact measurement, you could extrapolate what their pigment density might be?
Yes, you mean that we have to split people with cataract and people with intraocular lens and to look at only people with intraocular lens?
No, to take people that have different levels of nuclear sclerotic cataract, and then once they've had cataract surgery, remeasure them and be able to determine what factor to be able to use as a correction.
Okay, I understand. Yes, actually, we didn't do that. We just decided to, because people are old. They are, as I told you, at least 74 years old. So, of course, everybody has, at minimum, a slight nuclear cataract. So we decided to classify in the nuclear cataract group lens with opacities over 3. So that's a true nuclear cataract. So maybe it could have been interesting to look at people with nuclear cataracts between 2 and 3. That's you mean 2 and 3, or to see which.
But once they've had the cataract surgery, then you can get an actual reading to determine how much the first reading through the cataract was impacted.
But we didn't do that. No, that's a good idea. Yeah.
Okay. Any other questions? I think we have one last question here.
I want to ask you about the actual method to determine the cataract status. Do you use a reading center to decide, or each physician decide the status of a cataract subjectively?
No, actually, the images was screened by 2 different people in our team, but it was not a reading center.
So you take photos using the same street photographs?
Yes.
Same machines?
Yes, and because 2 people for the interpretation of the images.
And taking photographs use the same machine, because I also do the same experiments, and the color of nucleus varies easily depending on the CCD you used. Yeah, so it is very difficult to determine correctively to the color of nuclear cataract.
But for cataract nuclear, we used. I didn't mention that, but there was an evaluation with a slit lamp for cataract. Yes, for the evaluation of the cataract. Yes, I didn't mention that, but it was not based on the photograph, on the retina photograph.
So
what you mean? Yes, it was.
Then you don't use the slit photograph.
No. It was an evaluation with the slit
each physician decide subjectively.
Sorry.
Each physician decides subjectively.
It was a clinical grading.
Yeah.
It was, yes.
Yes.
It was by a
according to the
clinician.
classification. Yes, of course. Yeah.
Not by photograph. Mm-hmm. Okay. Are there any other questions? If not, thank you very much.